I'm going to try to catch us up a little bit here, because I know we're running a little bit behind. So the TAVR data, what does a surgeon need to know when answering questions about TAVR? Same disclosures, hasn't changed. So, what do patients want to know and what do surgeons want to know? I wanted to talk about both those questions because, you need to know what your patients want, but you need to know what you want. You want to know what the risk of dying is, risk of complications, both patients and surgeons. How quickly will I recover? The slide is running out quickly. How long will it last? And it's going off the bottom. I took out the patients, but it says how well does it work? Because as surgeons, we want to know what are the flow dynamics of these valves. We get an echo, and we go look at it, not just for leak, but we look at for the mean gradient, the effective valve orifice area, things that are important to our patients. So what's the data to tell our patients? Well, there's been 2 extreme risk trials. One of them was randomized, which was the Bertner trial, and it went out to 5 years, and there was no difference in survival. There was a 20% increase in survival for people that had TAVR over people that was treated medically. In fact, as you know, these extreme risks, almost everybody's dead at the end of 5 years. If you're extreme risk, treated medically, you're dead. If you look at the core valve, we wanted to randomize against medical therapy, but by this time, Bertner had come out and it was no longer ethical. But if you look at 5 years, the survival is 71%, which is almost right on top of what we saw for Bertner. So extreme risk has been approved by the FDA, and surgeons didn't mind that because they're extreme risk. We weren't going to operate on them anyway. These are inoperable patients, but we now have something to offer them. High risk, there's been 2 high-risk trials. The Bertner 1A high-risk trial, this was Mike Mack's presentation showing at 5 years. There's absolutely no survival difference between TAVR and surgery at 5 years between the Sapien XT valve and surgery. It's done at really good places. This is the high-risk core valve. And the high-risk core valve, interesting enough, TAVR was superior to surgery at 1 year, superior to surgery. Now, there was a lot of pushback because the way statistics were set up, when David Adams presented this, it was a 1-tele alpha. So when 2 years, I represented the data using a 2-tele alpha, and it was still superior to surgery. By 3 years, we lost superiority, but there was still a 6.2 delta in favor of TAVR. So for high risk, they're both approved. If you look at some of the other things here, all stroke was less in TAVR than surgery. And remember, in Bertner 1A, stroke was twice the rate in TAVR than it was in surgery, so everybody got all upset, oh my gosh, we can do this, but we're stroking everybody out. That's the last randomized trial where TAVR did worse than surgery in stroke. Every other trial, TAVR has either done better or as good as surgery. If you look at major adverse cardiovascular and cerebral vascular events at 3 years, still statistically superior for TAVR. If you look at the flow dynamics, the yellow line is, of course, TAVR, the blue line is surgery. TAVR had statistically better EOAs and statistically lower mean gradients at every time point that's tested. Notice we're in the single digits and we're approaching 1.8 here. If you look at quality of life, this bottom right, this is the Kansas City Cardiomyopathy Score, KCCQ summary. If you have a 5-point increase, that's a small increase in your quality of life, 10 points moderate, 20 point is large. Now you look, both of them get a 20-point increase. The difference is TAVR goes up a lot faster. By 1 month, these people are basically normal. And if you look at the endpoints at 3 years, one thing that we see in every randomized trial is surgery has more life-threatening bleeding and transfusion, more acute kidney injury, and more atrial fibrillation. Every single trial, these are the things that happen with surgery. What does TAVR have more? More major vascular complications, but in each generation it gets less, and more pacemakers for the self-expanding. It was equal in the original balloon expandable. With the skirt, it's gone up a little bit more. And if you looked at a force plot of this, it didn't matter if you're old or young, male or female, big or little, good EF, bad EF, diabetes, no diabetes, TAVR was favored. Prior CAB, no prior CAB, peripheral vascular disease, hypertension, STS above or below 7, TAVR was favored. So it's across the board. Now, as a surgeon, I was really bothered that TAVR beat surgery. We were the lead enrollers. I don't think we lost anybody. I thought we were going to win. And lo and behold, surgery had worse survival. So I went back and I looked at every death in TAVR and every death in surgery, and I constructed an instantaneous hazard risk of death. And these are the 2 curves. And the only place there's a statistical difference is between 1 month and 4 months. Because you see the hazard rate drops to 30 days, and then surgery, it goes back up and comes down at 4 months. Why would the hazard risk of death in surgery go up at 30 days? Anybody have an idea? What's the definition of death we use in surgery? Death by 30 days or in the hospital. So we could keep everybody alive for 30 days and we send them to an LTAC. And these old high-risk people then frittered away in the LTAC and they died. But if you made it to 4 months, you've lived long enough, you're going to get better. And after 4 months, your long-term survival is dependent on how well we get rid of aortic stenosis and your intrinsic risk level. And since these are the randomized trials, it goes on, and it's going to go on forever like this, because now it's how well we get rid of AS and you're interested. So if you really want to know somebody's risk, ignore their STS, look at the 1-year survival minus the procedural risk. That'll tell you what the risk of that patient population was. So for high risk, if we want to talk about TAVR versus surgery to your patients, and for you as a surgeon, you want to know, does TAVR versus AR show equivalent or better mortality? The answer to that is yes for TAVR. Hemodynamics, yes, it's as good or better than surgery. Quality of life, absolutely. Patient acceptance, I didn't show you any data on patient acceptance, but those of us that deal with TAVR know that everybody wants a TAVR. Somebody walks in my office and they go, I want a TAVR, doc, and I go, sorry, you have coronary disease. No, I want a TAVR. I read about it on the internet. Everybody wants a TAVR. It's accepted by patients. Morbidity, we're still working on PVL and pacemakers. Durability, we don't know. And we're never going to know from this high-risk trial. These people are 83 years old. They're going to die before we know durability. But it is moving to lower risk data. You can see the STS is coming down as we go, and there's 2 intermediate risk trials that have already been finished. There's the Partner 2A and the TAVR trial, and both of those showed non-inferior results to surgery. But more than being non-inferior, they're numerically better. Why is that important? Because if you're non-inferior but numerically worse, you can get into biocreep, so that every trial becomes a little bit worse. But being non-inferior and numerically better is a very strong signal that we're in the right direction. The Partner 2A trial was, it was stratified by access site, femoral versus transapical. It's a really good trial, over 2,000 patients with superb follow-up. Again, look at the age. They're 81 and a half years old with an STS of a little over 5.5. This is intermediate risk, but this is not an intermediate risk 70-year-old. This is intermediate risk 81-year-old, 82-year-old. One thing we see is that TAVR is always faster. Anesthesia times are less, procedure times are less, there's no pump time. ICU times are less. Now, those of us that are doing this now realize this is an old trial because none of our patients go to the ICU anymore, other than a rare one, and time in the hospital is less. So for the primary endpoint of all-cause mortality or disabling stroke, it was non-inferior to surgery. However, if you looked at the transfemoral only as treated, now we have to do some machinations to get ourselves there, but if you look at transfemoral only as treated, it was actually statistically better. This certainly gives you a hint as to where we might be going. And again, what do we see with TAVR? We see major vascular complications. What do we see with surgery? Bleeding, kidney injury, and atrial fibrillation. Every single trial, bleeding, kidney injury, and atrial fibrillation. In echocardiography, TAVR does better than surgery, but we still have an issue with PVL in this trial, still about 8% for moderate to severe PVL. If you have moderate to severe PVL, that's a bad thing. You die at a quicker rate. You got to get rid of that. TAVR, as I told you, TAVR was basically a first-generation trial. I presented this at ACC last year, and we also have a continued access, which was presented by Nicholas Van Meegen at TCT this year. Now, what we saw in TAVR was there was no difference in all-cause mortality out to 2 years. Now, bear in mind, I don't have it written down here, but the surgical mortality was 1.7% with an STS of 4.5. That gives you an ODE ratio of 0.38. 0.38. If you have that in your hospital loves you. That's the lowest OD ratio we've seen in any of the trials. Partner 1A was 0.68, Corvallis high risk was 0.61, Partner 2A was 0.71. All good surgery, all OD less than 1. This was tremendously good surgery, and yet still TAVR stood toe-to-toe with surgery. And again, this is the instantaneous hazard risk curve from high risk that I showed you a minute ago. I wondered about TAVR, why aren't we superior? Why is it the same? Because here's the hazard risk. It drops to 30 days and it stays down. Why doesn't it go up? These are healthier people. They survive. They don't go die in LTAC. They survive. Where's low risk going to go? Well, ask yourself, what does the trend look like here? We're going to drop the procedural lower and the curves are going to become flatter. At 30 days, we know at 2 years TAVR did well in intermediate risk with the Evolut valve. At 30 days, though, superior for TAVR, superior all stroke, superior less transfusions, superior cardiogenic shock, superior for atrial fibrillation, and superior for kidney injury. That's all pretty good at 30 days. Your patients want to know that. And where did TAVR lose still? TAVR still lost for major vascular complications and pacemakers. And look at the hemodynamics. The hemodynamics statistically better. Not only are we seeing single-digit mean gradients, but we're seeing EOAs of 2 and above. Why is that important? We know for Ramatula work, until you get an EOA of 2, you can't really increase your flow. So if you're an old person, that's okay. But if you're 75 and you still want to go out there and run, unless you have an EOA of 2, you're not going to be able to increase your flow without increasing your gradient. Quality of life, same thing. By 1 year, it's all the same, but TAVR goes up faster. Now, this was really interesting. We looked at a 6-minute walk change from baseline, and not surprisingly, TAVR beats surgery at 30 days, right? You have operation, you're not going to walk as well for 6 minutes. But at 1 year, TAVR was still statistically better than surgery. Why would that be? Because some people that have heart surgery convince themselves that I've had heart surgery, I am now injured in some way. And they never let themselves get better. They are psychologically damaged people. Whereas TAVR people, they have a TAVR, they come in a week, they go, I'm normal. And they just truck on through life like they're normal. But some of these surgical patients never let themselves, and we've all seen these patients. Why haven't you gone back to work? Oh, I've had heart surgery. I can't go back to work. Why don't you go play golf again? Oh, because I've had heart surgery. Now, this is what's really interesting. This is the randomized trial versus the continued access, and we showed you this. Zero mortality, 0.4% major stroke, and now the pacemakers are down to 16%. And this is for the 34 valve that was introduced, which we didn't have in the trial, which has really helped with our bigger sizes. Look at the EOAs, 2.5. This is starting to look like a homograft or a stentless valve. And the Pro is the valve we talked about that had a wrap. Even with the wrap, it maintains an EOA of about 2 with single-digit gradients. And at 1 year, 90% none to trace, 10% mild. This looks like a surgical valve. And if you look at the Pro, the pacemaker rate in the Pro was a little less than 12%. Why is that important? Because if you look at meta-analysis of surgical cases, pacemaker rates range between 3 and 11%. If we want to be competitive, we really need to be below 12%. I'm going to go pretty quickly through this. This was the S3 non-randomized trial where they then statistically went back and looked at it against the surgical arm of partner 2A. We can have a long argument about the statistics of that and the non-inferiority. I just want to get to some of the survival curves, but not surprisingly, it did very well. So ignore the statistics of trying to propensity match against a non-contemporaneous group and just look at the 30-day mortality for TAVR in this group that had an STS that was in the neighborhood of 5, 1.1%. And the stroke rate, 1%. When we started the low-risk trials, Mike MACC and I said these are going to be the low-risk trials are going to be the 1% trials. 1% mortality for surgery, 1% stroke. This intermediate group's already competitive, and the continued access for TAVI, 0, gives you an ODA ratio of 0. You can't beat that. And this is the statistical comparison against partner 2A. And again, we can argue about the statistics of this, but just look at the blue curve. It's an amazing curve. Again, the all-cause mortality, look at the blue curve, an amazing curve. And all stroke, again, we're now seeing improved results, TAVR over surgery. And now your moderate to severe paravalvular leak went from 8% to 1.5%. This is from the Reprise 3, Ted Feldman presented this at EuroPCR last year. We just published this in JAMA, and we compared against the core valve. And again, you can see these safety indices lie right on top of each other. And I expect this to be the next one out. So for intermediate risk, we have to ask ourselves the same question. What are we going to tell our patients? How do we do against mortality? TAVR does just as good as surgery. How do we do hemodynamics? We actually do better than surgery. How do we do quality of life? Well, you're going to be okay at 6 months, but you know what? If you want to get better faster, you do get better faster with TAVR. Patient acceptance, yeah, people still want TAVR. They haven't changed their mind. Morbidity, it's there, but it's getting less. You saw PVL rates starting to look like surgical valves, and the pacemaker rates are dropping down closer to surgical valves too. Durability, we don't know. The good news is these intermediate trials were designed as 5-year trials, and both the sponsors have now committed to following these for 10 years. Which is really good. We'll get the best data. There are 2 low-risk trials out there, the Partner 3 and the core valve Evolute randomized trial. Both these trials are basically done with the main body of the trial, but there's a CT leaflet motion abdominis sub-trial that both these trials are still filling because the FDA won't let us declare these trials closed and move to continued access so that happens. That being said, I really expect both these trials to be presented at the ACC next year. By 2020, if this data turns out to be positive data, which it will, then we're going to have a low-risk indication. And if you're not doing TAVR, you're in serious trouble. Now, do we have any low-risk indications out there already? Yeah, we have the NOTION trial. The NOTION trial was the Nordic countries, 70 or above, all comers. STS was about 2.3, so basically low risk. This is 5 years, all-cause mortality, TAVR versus surgery. No difference in this low-risk trial. So a couple of predictions for you as surgeons and to tell your patients. PVL will be largely solved and similar to TAVR with engineering designs by 2020. we're going to look just like a surgical valve. We know that surgery hurts your right heart. If I do an operation on you, your right heart function drops. It drops for about 6 months. It's a function of the pump. You can't help that. TAVR doesn't do that. And it's one reason why mitral valve function may be a little bit different. So we know RV function hurts, drops with surgery. It's not going to go away. Durability, well, we have some interesting early data to look at durability. This is 5 years of Notion looking at surgery versus TAVR. And you can see the TAVR valves show no fall off in the low gradients, no fall off in EOAs. This is 5 years of Advance. This was a European core valve trial. Again, no change at 5 years. And this is the extreme risk trial. Again, no change at 5 years. Pam Douglas did this for the Partner 1A trial, and Pam showed the same thing, basically very stable over 5 years. Now that's not, and this is Partner 1A, this is Mike Mack's work. Again, no change over 5 years. This is early data. We know as surgeons you really need to get out to year 7 or 8 before you know about durability. So we don't know about durability yet. We also know the older you are when we put in one of our valves, the slower they degenerate, and these are old people. So it's probably going to be the low-risk trial that's going to help us. Now lastly, surgery is a mature technique. We pretty much know how to do this operation. The people who taught me already knew how to do this operation. Where TAVR is young and is likely to undergo substantial improvements and is undergoing substantial improvements. And the technical disasters that we saw earlier have already started to disappear. We talked about this, surgery is technique-driven, TAVR is technology-driven. TAVR will enjoy a wider adoption than surgery. Just absolutely will. Now, why is this important? Because this is what's happening in the world. This is the growth of TAVR in the US and the TVT registry. For any of you who don't recognize it, if this was a business, you'd all want to invest in this. It's a huge upward movement. And this is surgical valves versus TAVR. The blue line is isolated AVR, the orange line is AVR cabbage, and the gray line is TAVRs. The last quarter of 2016, there were more TAVRs done than AVRs. And that's the last quarter that surgery is ever going to keep up. Now, interesting to note, if this was a zero-sum game, there'd be 0 AVRs done right now. It's gone down, but not that much. So if you do this, you're not going to stop doing surgery. Surgery's never going to go away. There's always going to be a need for surgery, but you really want to be able to do both. And access, if you look at access across the country now, it's 94.2% transfemoral, and alternative access is falling way, way off. And we really need to divide alternative access into those that put a hole in the chest, like direct aortic or transapical, versus all the other ones. Because all the other ones are going to do just as well as transfemoral, because they don't put a hole in your chest. And the median length of stay has gone down, the 30-day mortality has gone down, and if you look at TAVR, the number of people that go home has gone way up. We know if you go home, you're going to tend to do better. Now, there is one statistic that I've talked to Mike Mack about that bothers me, and that is that 40% of the 30-day mortality in TAVR happens at home, meaning they go home and they die at home, 40%. It doesn't happen in surgery. Why? Because we keep you there a lot longer, and you may die in an LTAC, but if we send you home, we're usually comfortable you're going to go home. A lot of these people we're sending home so early, I'm worried that we're missing some things. 40% of your deaths in the first 30 days are happening at home. Something's wrong. So what do patients want to know? What do surgeons want to know? Well, the risk of dying, yeah, with TAVR, it's no worse than surgery. It may even be better. The risk of complications, yeah, they both have unique complication signatures. They're slightly different. But PVL doesn't kill you quite as quickly as renal failure does. Renal failure is a bad thing. How quickly will I recover and how well? TAVR recovers a lot more quickly. And you seem to catch up with your KCCQ, but we saw from that 6-minute walk test, you may not get back to a normal life. How long will this last? We don't know the answer to that. In fact, I think somehow as surgeons, we've often deluded ourselves as our valve durability. I see a lot of 15-year studies for valve durability, but if you look at the mean follow-up, it's 6.5 years, and they call it 15-year follow-up because the longest survivor was 15 years. It's really not 15-year follow-up. And then they cut off my last slide of how well do these valves work. They work better than surgical valves from a hemodynamic standpoint. So right now, when we look at the risk spectrum, there's 2 lines we don't cross. There's one at the top. Basel mentioned this. If you're so sick that I fix your valve but you don't get better, you're futile. You're cohort C. We'll just leave you alone. And then there's a line that we don't go below because we're instructed by the FDA that the lowest we can put these TAVR valves is intermediate risk. But both these lines have been moving to the left. Durability is the big question. If durability is found, my prediction is that pretty soon anybody that's a candidate for a tissue valve will be a candidate for a TAVR valve. Thank you very much.